And we are live on Facebook. Hello, 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 everyone. This is Dr. Latoya Wells with Wells Legacy Health and Wellness. We're here for another Wellness Wednesday. And you can see I have my sissy here with me again, Brandy Branch. She's a certified nurse midwife. She's the owner of Branch Mom LLC. So she's going to tell a little bit about herself. But last week I said that was our last Wellness Wednesday discussing diabetes. Well, I got a treat for you tonight. We're going to be discussing diabetes in a pregnant woman, and who else to have other than my sister, who I consider the expert in all things women health. So she's going to be here with us tonight, and we're going to be discussing gestational diabetes and diabetes in the pregnant woman. So, Brandy, tell us a little bit about yourself. Just refresh their memories.
Hello, everyone. Good morning for some people, good evening for some, like myself. I am like Brandy Branch. I am certified nurse midwife, and I have been doing women's health for 15 years now. I love all things women's health from waist down. So anything that goes waist down, I'm good for. Um, I started this journey actually in the surgery department and did start doing some OB surgeries and just fell in love with women's health and all things women's health. My back right now, I'm active duty Air Force in in the Air Force, of course, and I'm stationed here in Germany. So that's why I said good evening for those that are watching overseas. Thanks for joining us. I am happy to be here again, talking about all things women's health and to dive into a little bit of gestational diabetes. So yeah, that's me.
Thank you. I sent her message very last minute. So I'm so grateful. And then I was like, oh, it's like midnight at her time. Are you sure you're gonna be able to do this, sis? And she was like, of course. That's some
Of
sisterly love
course, of
for you.
course. I'm gonna support my sister.
I
Absolutely.
appreciate you so much. As you guys can remember, last time we talked about women's health and we talked about all things women's health, we touched on quite a few different topics, right? And I know this is one of her passions. This is one of the things that she gets really excited about, helping pregnant women, helping women who are looking to become pregnant, doing, the prenatal, the postnatal, doing pregnancy and all of that. And so, what better way to wrap up Diabetes Awareness Month? We're talking about diabetes in the pregnant woman. So, Sissy, when you are seeing patients, I know for us, we screen our patients routinely for diabetes. We check their A1C at least, if we try and check it at least every 6 months, right? To see, and on that annual physical exam, we're checking for diabetes and looking for the signs and symptoms of diabetes. Tell us a little bit about what you're looking for and what that process is with pregnant women.
So, what we're looking for when a woman becomes pregnant, usually when I'm in the office, they would come see me first. I'll be the first person they come and see and do our nurse education, and we talk about their pregnancy and based off their risk factors. So some risk factors for gestational diabetes, if you're of African American descent, if you're Native American, Pacific Islander, if you come in with a BMI greater than 25 on your initial visit, we do a pre-screen for you for gestational diabetes. So we ask the questions, or if you've had gestational diabetes before in pregnancies, or if you have diabetes, we wouldn't necessarily do the test because you already have pre-gestational diabetes. So to do the screening, we wouldn't even do that you've already ruled in because you have diabetes. So yeah, we talk about, and I do what we call the initial testing, which is a 50-gram glucola testing. Yeah, that glucola drink, I had to do it, and ooh.
I did too. It's nasty. Oh my gosh. And listen, I had hyperemesis gravidarum really bad. So imagine me trying to drink that 50 ounces. But I digress. We're going to continue on.
Now there are alternatives to taking the test for some people who can't tolerate it, or some people who've had gastric bypass and face dumping syndrome. So there are alternatives that we use, but the glucose glucola drinking is the gold standard.
Mhm.
So yes, but that can be a whole nother conversation, because that has become a bit of a rift in the OB world as of lately, of
Mhm.
glucola testing and stuff like that. But anyway, we do that, and depending on what their numbers are, and some of the numbers that we're looking for. So your what we call your fasting glucose, your 1 hour, we want it to be below 95, right? So if you come in as 95 or above, we say, okay, well, now we need to do a 3-hour testing. And the 3-hour testing requires you to fast for at least 8 hours, which is kind of challenging for pregnant women like yourself who had hypermesia. Like, that's challenging, but you do the best that you can.
Mhm.
So we have you fast, and you go and you do the 3-hour testing. Now, the 3-hour testing is the 100-gram glucose, the glucola. So yes, you go back and you drink and you sit and you wait. You sit and you wait for 3 hours. So I tell people just to wait for 3 hours in the lab, and we get the numbers back. And the numbers that we're looking for, anything below one, that we want to rule you out, is anything below 140. So if you start getting into, and each institution, it varies. So ACOG says between 130 and 140. So it just depends on whatever your institution is, on what numbers they want to go for, ruling you in or ruling you out. But
Mhm.
ACOG says 130 to 140 is the numbers that we're looking for, that you be under. So if your 1 hour is 195, you ought to be, we just rule you in. And then we do the 2 hour and then the 3 hour. So if you get two numbers that are above the 140, which is around usually like 180, 150, we start like, all right, because usually that first number is going to be high, and we expect that. So that's why we do the second and the third, and we just use the 2 out of the 3. And if you have 2 out of the 3 numbers that are high, then you're ruled in for gestational diabetes.
Okay. And so once you have that information, that can be scary for a pregnant woman, right? It can be scary for anybody to hear that they have diabetes or they're at risk for diabetes. But as a pregnant woman, you already have all these things that you're concerned about and things that could happen or could go wrong. And then to hear that you have gestational diabetes, that can be a lot. So what is that process? Talk to us about the process that, okay, they've done the testing, they've made it through, they got the numbers back, they do have gestational diabetes. What does it look like? What does that next visit or that conversation look like?
So the next conversation looks like what we call diabetic teaching, which they come back to me again for diabetic teaching. And I have a whole PowerPoint that I go over with my patients, and we talk about, I explain to them what gestational diabetes is, how did they get it? And it's not something that they did or didn't do, right? Because any pregnant woman can get gestational diabetes.
Mhm.
So you're not exempt from getting it because you don't have the risk factors, or you could be the most healthiest person in the world. You're not exempt from it. It's not, oh, because you're this, you get it. So, I have to reassure them that's nothing that you did.
Right.
Because the way and we usually, like I told you, we do a pre depending on what it is. But sometimes if they have no pre-existing or anything like that, we do it between 24 and 28 weeks.
Okay.
So in the same testing. So when they come in to see me, I go over PowerPoint with them, and I explain to them what gestational diabetes is. It's just the pancreas. Our pancreas has our insulin. I'm sure you talked about it in your series about how our pancreas has insulin and sugar, and it's a hormone in our placenta, which we think it's the HPL hormone, which is the human lactogen
Okay.
hormone. So between 24 and 28 weeks, that's when that hormone starts revving up a bit, right?
Gotcha.
And that hormone produces a lot of sugar. And if your pancreas is not producing enough insulin to give you that balance, then
Mhm.
you got too much sugar in the blood, which rules you in for gestational diabetes. And to
Right.
fix it is to have the baby. So
Yeah.
I go over and I talk to them about it. We go over a diet that I give them, like a diet, like a 2,000 calorie diet, and things that they can eat. And then I give them a chart, because they have to take their blood sugars 4 times a day. One
Okay.
as soon as they wake up in the morning, one right after they finish their breakfast, so like 1 to 2 hours after breakfast, and 2 after lunch, and then after dinner. And then I
Mhm.
just tell them, like, hey, these are the numbers that we're looking for. And usually we're looking for anything that's above, for your fasting, anything above 95. We want you to write it down. Those are the things that we're looking for. And I explained to them that there's 2 different types of diabetes for gestational diabetes. You got your A1 and your A2. Everyone rules in for A1. Everyone rules in for A1. That's basically what we're saying is nutrition control, right? Or just we don't have to give you any medication. We just want to monitor your sugars to see if we're going to have to give you medications. So that's the purpose of having them do the chart. And I tell them that, hey, after you eat breakfast, no cereal bars, because that will make just eat a breakfast. Do not skip any meals, because some people feel like if they skip a meal, oh, my numbers will be low. Actually, it just makes it worse. The numbers will go up. So don't skip a meal. Have 3 meals and snacks throughout the day. You do not have to take your blood sugar after your snacks, but after your lunch, after your breakfast, your lunch, and your dinner, the 3 big meals, take your blood sugar. And if it's over 140, I ask them to write down what you ate, because sometimes rice can be good for some people and rice can't be good for other people, right? So just write down what you ate, and then it tells us like, hey, maybe you need to stay away from this right here, because this may be causing your blood sugar to spike a bit. And it tells you, when you come see us, during your week or weeks for your next appointment, you're looking at yourself and your nutrition and saying, this, I may not need to eat this because it's making my sugar go up. So it's all about diet control and nutrition control. And then we give you a consult to a nutritionist, to talk to a nutritionist to help you with that and tell you like, hey, what foods, what diets, and the nutritionist goes over that because that's their wheelhouse with things like that. So then, after that, and then we give them the monitor, the strips, the needles, everything. And some people are afraid to take their blood sugar. They scared to stick their little finger. So I teach them how to stick their finger. We go through all of that. And they're like, okay, my husband's going to have to do this, or my partner's going to have to do this. So I teach the partner how to do it. And then it becomes, and it kind of, like, okay, hey, it's nothing that I do. But that first initial is a lot of reassurance. Like, hey, you didn't do anything. So don't think that I did something to get gestational diabetes. You didn't do anything.
Right. Yeah. I can remember seeing, when I did my OB rotation, I can remember seeing a patient who had gestational diabetes, and she was so in her head about what she did. Well, I shouldn't have drank that soda, or I shouldn't have had that candy, or I really was craving this. And so that gave me diabetes. And we had to do a lot of education on, no, that did not give you diabetes. And just understanding the process of how diabetes is developed. And, but again, I am not an expert in women's health. I would prefer not just go down below the waist, but if I have to, I will. So after you have that initial conversation with them and then you're continuing to follow up with them, are there any risks or any side effects or complications, shall I say, from gestational diabetes that you have to monitor for?
Yes, and those are the things that we go over too. And one of the biggest thing that I call them water babies, but the technical name for it is macrosomial babies, the big babies, those 9-10 pounders we worry about. So we worry about babies getting too big, and then increase the risk for shoulder dystocia, have to have a C-section. And then your baby, well, for all babies, and like I said, not all, for whatever institution you at, once your baby is born, it is recommended to check the blood sugars of the baby, because again, blood sugar of the baby is high. So some of the risk factors, some of the complications that can happen is like a macrosomial baby, a baby above 9 pounds or more. And also it depends on your background, because some Samoan descent, they have big babies. So, you take all of that stuff into consideration as well. So you, like I say, a risk factor for a C-section. If it's uncontrolled, if you're not keeping up with your numbers, or if you're just not being compliant, you're going to have to be on an insulin drip during your pregnancy, during your labor, but also be put on insulin, which is the gold standard. We used to use the pills, glucophage, but now it's insulin. You'll have to be put on insulin. Then you'll have to come back into me so I can teach you how to give yourself insulin. So those are some of the biggest one is macrosomia. We worry about having that big baby because it's uncontrolled. So that's why. And then we start, depending on if you are A2, which is, we need to give you medicine, we'll bring you in for weekly surveillance around the 36, 37 week mark. sometimes earlier for whatever your particular situation is. We'll bring you back earlier to do antenatal testing weekly or bi-weekly or whichever is recommended.
Okay. And so, yeah, I've seen those big babies and it's like, whoa. You call them water babies. I've heard the term sugar babies. Because the mom had diabetes and their blood sugars were uncontrolled and they end up having these big babies. Now with diabetes, whether it's juvenile or type 1 or type 2, there's usually signs and symptoms that we look for. And many times in just doing a standard urine dipstick, we see that the glucose of these individuals, and some may have protein because they're spilling protein. Is that something that you guys monitor women for as well? What other signs and symptoms might they experience? Is it the same that we would see with regular diabetes?
It would be the same that you would see with someone who has diabetes. The sweating, the nausea, all of the things that those things we look for. And also you have a risk. Women with gestational diabetes have a risk of developing hypertension. Sometimes we even preeclampsia, just depends, the preeclampsia. So they have all these risk factors of developing other things later on in the pregnancy that we do watch. We do watch their urine. We watch their blood. We watch their blood pressures because the blood pressures can go up and those things like that. So yeah, we watch those as well. And we tell them about the same. Hey, if you start feeling this, if you start feeling nauseous, sweating, clammy, vomiting, let us know. Come into our triage, and we can see you, or just let the doctor know when they come in for their appointment.
Okay. And so when you see a woman who has gestational diabetes, is there a chance that does that increase her likelihood or chance of developing diabetes later in life? Because I've heard that. And do you have any experience with that?
Yes. So ACOG says that women with diabetes, about 50%, so which is a high number, about 50% of women would develop type 2 later on in life. Okay. So you can develop type 2. There is a test that we do afterwards, after you've had your baby. So in your around your 6 week, and again, institutional based. So whoever your healthcare provider is, they can do a test afterwards, another glucola test, but it's a 75 glucola test, not the 50 or the 100. It's the 75 that they will do to check to see, and then we'll just keep monitoring you. But you do have a 50% chance of developing type 2 diabetes later on in life. So it's important that you keep an eye on that and keep monitoring your hemoglobin A1C. And when you're speaking to your primary care, to let them know, because sometimes, they don't all review your OB charts, because once they figure out you're pregnant, you hands off.
You're no longer their patient. We send you OB. What now?
You're pregnant, like,
yeah, exit left the OB.
So when you go back to your primary care, when we release you back at your 6 weeks to your primary care, because we do release you back to your primary care, you just let them know, like, hey, during my pregnancy, I did have gestational diabetes. So they are aware to make sure they're keeping on top of your hemoglobin A1C, but you're your biggest advocate. So make sure you're letting them know.
Okay. And then how does family history, like if a woman who's primarily healthy and does not have any signs and symptoms of gestational diabetes, but they develop it during the pregnancy, do we look at their family history to see if anybody has had type 1 or type 2 or even gestational diabetes? I would assume that would put them at a higher risk for developing gestational diabetes.
Yes, I've had patients who were healthy, had no issues or anything like that, and had gestational diabetes. And once we go into the family history, because that is a risk factor as well, once we go into their family history, we find out like one of their parents or both their parents have diabetes, a sibling may have diabetes, and that's the risk factor right there. Like, okay, it was not say bound to happen, but there was a chance for you to develop gestational diabetes and type 2 later on after pregnancy.
Definitely. We know that there's a correlation with the familial history for type 2 diabetes, but typically, and we have women who are having babies later in life now, right? So
Mhm.
typically individuals develop diabetes at some point, but we're seeing younger individuals develop type 2 diabetes. And I just attended a conference, and we really have to be careful because it can actually be type 1, and we're just now seeing the signs and symptoms of it. But
Mhm.
with women who are pregnant, the chances of them developing type 2 diabetes, as you mentioned, is higher if they have a family history. And
Yes.
so it's important, one, that they're getting their annual physical exams and getting the screenings before they get pregnant, right? Because if they are at a higher risk, then that OB can begin to, doing that initial appointment when they're doing all the health assessment, the review of system family history, you guys are getting all that information so that way you're able to develop your plan of care.
Absolutely. And that's why it's important when people are family planning, when people, pregnancy is wonderful. It's a wonderful thing. I love it deep down in my soul. That is my thing. I love it. Pregnancy is a beautiful thing. But when we talk about pregnancy, people talk about, oh, I'm pregnant now. Now I need to do all these things. No, let's talk about it before. Let's make it
Yes.
plain, right? Let's start taking that folic acid. If you're not taking it, let's get those tests. Let's see what I'm predisposed to. Let's see what you're, and it's not just you, it's your partner, whoever
Correct.
you want to have. What are they predisposed to? What is going on? What is your history like? Hey, let's do these things to, that's family planning. And people try to plan once they get pregnant, like,
Yeah.
getting pregnant is wonderful. It's a wonderful thing, but hey, let's start doing those things before. So hey, I'm predisposed to gestational diabetes. So when you come in and see people like me and talk to me, you can tell me, hey, because I ask your family history, but you already know, like, hey, this is my family history. This is what. A great historian, and I can say, okay, these are tests that I need to run.
Right.
This is what I need to do. And and it makes for a good pregnancy. It makes for a good, what I call it, birth story, because I want you to have a fabulous birth story.
Yeah. Yeah. When we talk about pregnancy and the delivery process, does that process look different for a woman who has gestational diabetes? I know you said that they would be on an insulin drip, but like let's just say they have their birth plan written out and it includes them having gestational diabetes. Is there any major differences from someone who does not have diabetes versus someone who does with their birth plan and their delivery?
So everyone doesn't need an insulin drip at delivery. If you're on medication and you're just, insulin drips are for those people who are like uncontrolled and the numbers has just been all out of whack, and we've just been holding by the grace of God to get them to delivery. Those are the more people, that more high risk people, what I call. But some people that are being diet controlled the whole time and their numbers have been great. The only difference in their delivery process is that we just take their blood sugars. So we'll take their blood sugar when they first get admitted. They'll get a blood sugar, and then throughout, it just depends, again, institutional and whoever the healthcare provider, whatever their preference is. They may just take one when they get there, and that's it. Some say, hey, take it every couple of hours or stuff like that. So it just depends on what the institution and what your healthcare provider wants to do and how they want to manage it. But some people come in and we don't do anything different to them, but just take their blood sugar. And then when their baby is born, we let them know, hey, the pediatrician may want us to do blood sugars on the baby because sugar is getting into the baby. So we want to make sure the baby is good. And then with the macrosomial babies, those big ones, we worry about respiratory problems because big babies have little necks, right? So that's the biggest thing that we worry about is respiratory issues, because they're just big and the breathing can be a little problem. So those are the things that we look out for after delivery. We watch for the baby.
Yeah, that's really important. I know you talked about family planning and planning beforehand. How do you handle women who have not necessarily had prenatal care and they get to the point of coming to see you later in the pregnancy and we find out that they have gestational diabetes?
The care doesn't change for me, right? And I don't judge. I just, they tell me why, because some people are afraid. I work in a hospital, and some people are afraid of hospitals, especially Black women. And they have a, that's a whole nother subject, but we understand that African American women are 3 to 4 times likely to not make it through their pregnancy, right? And they understand that those numbers are out there alarming, and people understand that. So I don't judge, for one. And then two, I just find out, hey, why are we not doing this? Why did we wait so late into our pregnancy to receive prenatal care? And being in the military, sometimes it's not even their fault, because they find out they're pregnant, then they PCS, and they go from one place to another, and that care kind of get lost, not lost in the sauce, but they just kind of lose that, what we call that standard, that continuity of care, because they're in the middle of PCS. So that's what I seen a lot lately, is because of PCS, or they're just afraid and don't want to come into a hospital to be seen at all. But they find out that in the military world that they have to deliver, they can't deliver at home, for whatever reason.
I didn't know that.
The military won't pay for it. And in some places the military won't pay for it. Like when I was in Japan, they won't pay for a home delivery. So they are moved towards coming to the hospital to deliver, and they're just so afraid. So with those patients, we just talk and we have a conversation, and it's about educating them and making them feel comfortable, making them say, hey, this is your show. I tell people all the time, look, this is your show. I'm just in. You just allowing me to be in a part of your show.
Yeah.
If you want to swing from these chandeliers, you can. But I just want to make sure that you understand the risk, that you understand the benefits, the risk, what happens if you say no, all of that. I want to make sure that you understand. And if you understand, I'm going to do whatever you would like to do. And again, I'm still going to reassure and educate. That's pretty much part of my job, is just reassuring and educating.
Yeah. Yeah. And you do an amazing job at that. Like,
I love it.
If you want to have a baby with an amazing doula, fly to Germany or have her come to you so she can be there to support your birth story when you're ready to have your baby.
I absolutely, nothing gives me greater pleasure than doing it. I love it. The challenges, the fun, the ups, the downs. I just love it. I love it. People say, why are you still in the military doing this? Like, you could be making so much money outside. I was like, because I'm having fun.
Yeah.
When I stop having fun, then I'll think about changing. But right now, I'm just having so much fun. I love doing it. And I just love seeing the outcomes. And yes, there are some days where you don't get such good outcomes. Yes, that happens. And I'm not going to sit here and say everything is all peachy rosy and every delivery is. Some deliveries have you on the edge of your feet, edge of your seat, edge of like your butt's cheek. Like all of that. But at the end of the day, I absolutely love it. It gives me so much pleasure, so much joy to do it. So yeah. And I love educating, because I feel like an educated patient is a more empowered patient, and they're more likely to agree to what you are doing or what you want to do, because they know that you want to tell them step by step everything that you want, everything that could happen, or everything that could potentially, like all of those things. Once you start talking to them and treating the person and treat them like an individual, they would be agreeable to any and everything.
Yeah.
And sometimes they're not. But support them not being that. So, support that they don't want to do it. Support it. They'll still be agreeable. Yeah.
Yeah. I am a big proponent of educating and helping my patients to be an advocate for themselves. And that's part of our mission with Wells Legacy Health and Wellness, right? Because if they have the information, if they're knowledgeable about their healthcare, then they can be an active participant in their healthcare and help call the shots, and not just kind of sit idly by while someone else is making decisions for their healthcare. And because either they're afraid or they don't understand. And so one thing you said that I didn't necessarily understand, and some of the viewers may have the same question: what is PCS? What does that mean?
Oh, so PCS in the military world means you're just rotating from one duty station to another. Okay. So yes, it's permanent change of station. Okay. For us in the military world. So we go from all over the world. We move every 3 years, every 2 to 3 years. Like myself, it's every 2 to 3 years. And if you're going from, like, in my case, if you're going from like overseas to stateside, it takes a little time, especially if you're going to a base that doesn't have care on base, or, it may be a smaller base. You have to find care off base, and, not necessarily find, because they'll refer you, but you still have to set those appointments up. They take time, it takes a little time. So that's why sometimes I tell them like, hey, it's like, oh, you didn't get any prenatal care. And I was like, no, necessarily probably didn't get any. It's just, going through that season of PCSing and trying to find a healthcare provider and be referred and do all the things. So that can cause a lot.
Right. And that can be challenging, not even when you're not in the military, finding a healthcare provider. And we get it. We definitely understand. We're coming to a close here in just a second, but I just wanted to highlight a few things that you talked about. You talked about the signs and symptoms. You talked about what gestational diabetes is, who's at risk for gestational diabetes, some of the screenings that can be done for gestational diabetes, the treatment. And one of the most important things is the time that you spend educating your patient and those women and their partners on gestational diabetes and how to live with it and manage it throughout the pregnancy. And some of the things that we need to look for in the baby, some of the complications and things of that nature. And you did touch on something that is, I think we talked about during our last talk, was the impact of pregnancy and delivery on the Black woman, the minority woman. And that's still a major concern. That's still an issue. And it's sad. We're in 2023 and we're still having women dying. I just was listening on social media, just kind of scrolling, and 3 stories of sisters and family members telling about their sisters or their daughters who died in having a C-section, or after delivery of the babies, they passed away. And so I'm grateful for you, and I'm grateful for every other healthcare provider who has a passion for educating women on and helping them to create their perfect birth story, regardless of the complication or how high risk they are, because it's important.
Right. It's extremely important.
Yeah. Anything else you want to say?
No. But just always remember, one of my education pieces when I tell my patients who come in with gestation, when I'm teaching them about anything, please do not tell me you got information from social media.
How many times have you heard that?
I'm like, if you're telling me that you made this choice based off of somebody's social media account, and now there are some good ones out there, like Babies After 35, who's on Instagram. She is phenomenal. She's a phenomenal OBGYN. And she puts out facts, she debunks things. So there are some out there, but then there are a lot more out there that put out so much just terrible information, and they're trying to sell you something. If they're trying to sell you something, that's a red flag. So, so I just say, please, just be careful and just really screen your social media platforms and who you're following and who you're getting information from, especially when it's talking about your health. We're talking about your health. So even with gestational diabetes, like I said, there are some phenomenal ones out there. And like I said, Babies After 35, I love her. I follow her. She is a phenomenal OBGYN, and she puts out really valid information, evidence-based information. So I just want to leave with saying, when you are getting information about your healthcare, especially about gestational diabetes, your pregnancy, diabetes in general, please be sure to be getting it from reputable sources like ACOG, the American Diabetes Society, those reputable, or if you do follow a social media page and that is your right, just be sure that they're putting out evidence-based information and they're not trying to sell you something.
Correct.
So yeah.
Tell us a little bit about your business and where we can find you.
So you can find me at www.branchmom, and that's BRANCHMUM.com. I am doing doula services. Right now, I'm offering doula services. I am a certified nurse midwife, but my role in the Air Force is a registered nurse because I got my certification as a midwife while I was active duty. But I do a lot of consultations and a lot of birth education. So you can reach out to me for a consultation. You can email me at brandy@branchmom.com. And you can follow me on, Instagram at branch_mom. So MUM.
Okay. Thank you so much. And I'm so proud of my sissy. She was just recently promoted to major. So congratulations. And she also received the Florence Nightingale Medal award. I wasn't able to go, I was sick, but I'm so, so proud of you. And I'm so glad that we're able to connect, even though you're all the way in Germany. I'll be glad when they PCS you back to Florida.
Well, I'll be home next month again, so I'll be back.
I get to see you in a couple of weeks. But thank you so much for taking time.
Absolutely. Thank you for having me, Susie.
I appreciate you, and we will talk to you later. Until next time, Wellness Wednesday watchers, stay safe and be well. We will talk to you soon. This is Dr. Latoya Wells and Brandy Branch with Wellness Wednesday. Have a good evening. Bye-bye.